Today we'll start our Harrison-based discussion, which will be from pain section. In pain, first we will study about pathophysiology and management of pain. So starting about pain. Now, what is pain? It is an unpleasant sensory and emotional experience which is associated with or resembling that associated with actual or potential tissue damage. This definition was given by IST. So what does this mean? Any kind of acute or potential tissue damage will be there. It will create an unpleasant sensory and emotional. So you should know it is sensory as well as emotional experience that we encounter in. Going further, it is always a personal experience. So we build that experience on our livelihood. Suppose we are now a 2 year kid, a 5 year kid. So our perception of having a pinprick injury will be different by from another guy, and this will carry all our lifelong age. So our pain experience is different of every individual, and it is a lifelong process. So through their life experience, individual learn the concept of pain, how it feels, and how it happens, and how much emotional component is associated with any kind of pain. So when we go further, there are two different type of mechanism which are associated with pain. One is peripheral mechanism and other is central mechanism. Now, before starting with pain, we should know what are the pain receptors. So, my friend, three nerve endings. What I'm saying, three nerve endings are pain receptors. These are the first things which are stimulated any kind of pain. So, in peripheral mechanism, we will start with peripheral afferent nociceptor, which is our sensory afferent nerve fiber. Now, we all know that there is a nerve fiber. When we touch anything, that stimulation will be carried by nerve fiber. So, nerve fiber is made up of lot of fibers, which are A fibers, B fibers, and C fibers. And we all know in our physiology what we were taught that A fibers are thick myelinated fibers, B are small myelinated fibers, D, C are thin unmyelinated fiber. Now, A alpha fibers are meant for proprioception and motor. A beta are meant for fine touch and pressure. A gamma are meant for motor. A delta for sharpening, and C for dull chronic pain. So in all these fibers, what we are seeing that A, delta, and C they are meant for pain. So they carry pain sensation. So all the fibers in nerve are there, A, B, and C. In them, A, delta, and C are the fiber that carry pain. A, delta carry sharp pain, and C fiber carry dull chronic pain. Now you can see this diagram by Harrison. Now here there is a peripheral nerve. In this, there are fibers which are A, beta, A, delta, and C. Now these A, delta, and C fibers, you are seeing that they are carrying pain with them, and they are going to dorsal root and spinal cord. So A, delta, and C fibers which carry pain. Now we know that A delta and C fibers carry pain, but something should be there to stimulate this fiber. Now, what is this? So, any nociceptor which can be heat, cold, mechanical distortion, pinch, any change in pH, particularly acidic environment, any application of chemical irritants, including adenosine triphosphate, serotonin, bradykinin, histamine, and especially TRP1. All these act as a nociceptor. So what all these things will do, they will irritate our nerve fiber. When nerve fiber will be irritated, it will carry pain. And through which they will carry pain? They will carry pain through A, delta, and C fiber. Now we will move further. Now further, there is the other special thing known as sensitization. Now what do we mean by sensitization? Now before starting sensitization, we should remember two most important things of sensitization. That is peripheral sensitization and central. Peripheral sensitization is at the level of peripheral nerve terminus, and central sensitization is at the level of dorsal hollow of spinal cord. Remember, these two are the MCQ points which are frequently asked in any kind of exam like NEET PG and medicine. Now, what do you mean by sensitization? Suppose whenever a nerve fiber is full of action potential, we all know, and our resting memory potential is about -90. When any stimulus comes, sodium channels open and they make memory positive, and -90 will get converted to +50, something like that. Now, suppose earlier 1 ml of acid or 2 ml of acid is poured on my skin, and my threshold changes from -90 to +50. But due to some other factors like prostaglandins, leukotrienes, this same effect will be happening by 1 ml of acid. So what they are doing, they are lowering my threshold. Earlier, my basic set point was minus 90 milliwatt. It is converting into plus 50. Now, due to these prostaglandins and nerve growth factors, my resting number pressure is not minus 90. It is something about minus 70, minus 60. So they have changed my threshold. So from small injury, I am receiving pain, that much pain that I was receiving with a lot or more pain. That is sensitization. And that is peripheral sensitization. It differs from central sensitization, how I will tell you. Now, we all know that central sensitization happens at the level of dorsal horn of spinal cord. Now, this is our spinal cord. Suppose this is our spinal cord. This is our dorsal horn of spinal cord. Now, from peripheral nerve, stimulus is coming to dorsal horn of spinal cord. Now, here some neuroplastic changes happen. Now, what this neuroplastic changes will do in this dorsal root of spinal cord? Now, we all know that each spinal cord is related to a particular dermatomus skin. Now, if suppose I touches, this touch will also be received as a pain by this dorsal horn of spinal cord. Why? Because of some neuroplastic changes that is happening in there. So they will continuously and consequently will receive a pain sensation whenever there is a normal touch also. Because of this, because there are some neuroplastic changes happening in spine. Now, how it differs from peripheral sensitization? In peripheral, there should be a pain always. But what I mean that earlier 2 ml acid was causing pain. Now 1 ml of acid is causing pain. But in central, what is happening that all the time there is neuroplastic change. So even a touch, which earlier was not a pain, now it is doing pain. That is known as allodynia. So we should remember how to differentiate between peripheral sensitization and central sensitization. I hope you understand. Now we will come to central mechanism. Now central mechanism of pain is by dorsal horn of spinal cord. Now we will now draw a diagram of how ascending pain sensation is carried out by peripheral nerve and spinal cord. That is very easy. Now you all should draw the diagram with me. Now how we will start. Now first most important thing we know that in our spinal cord there are tracts and tracts carry sensation. Now we all know that there is one tract known as spinothalamic tract. It has two parts. One is anterior and other is lateral. Now this lateral part carry pain and temperature, and this anterior parts carry crude touch. Okay, so we are now thinking that spinothalamic tract is there. There are two tracts. One is anterior and other is lateral. Lateral carry pain and temperature, and anterior carry crude and touch. Now, just draw diagram with me. Now, this is a spinal cord suppose. Now we all know that pre-nerve endings, they act like a receptors. Pre-nerve endings. And what are stimulus? pH, bradykinin, they all will act as a stimulus and they will irritate this pre-nerve ending. Now, in spinal cord, there is motor root and sensory root. And this part in sensory root is DRG, dorsal root of ganglion. Now, who will carry this pain from pre-nerve ending? A delta and C fiber. This is A delta and this is C. Now the A delta and C fiber will carry pain and they will terminate at DRG. Now, when they terminate DRG, this is our first step body. Now, from DRG, further fibrosis arise, and they will terminate in this spinal cord area. And this special area in spinal cord is known as substantia gelatinosa. Now, see this diagram. You are seeing spinal cord. See this diagram. This is special area which is known as substantia gelatinosa. So, from free nerve endings, they end in dorsal root ganglion, from where first order neuron will arise. Which order? First order neuron will arise. This first order neuron will go further and they will terminate in spinal cord in area known as substantia gelatinosa. From there, second order neuron will arise. Now, this second order neuron will decussate in spinal cord. You are seeing they're decussating at the level spinal cord. Now, this is also MCQ that at spinal cord, decussation happens of second order neuron. Now, so the second order will now move upwards and they will go to thalamus. So, fibers are going from spinal cord to thalamus. That's why they are known as spinothalamic tract. And as they are in lateral part of spinal cord, they will be called as lateral spinothalamic tract. Now, this is a bundle of lateral spinothalamic tract. Now, when they will move upward, these lateral spinothalamic tract plus there is anterior spinothalamic tract and there's another tract known as tectospinal tract. The combined they are known as spinal lemniscus. What they are known as? They are known as spinal lemniscus. So till now, so this touch any kind of stimulus, free nerve ending will carry this pain. This pain will be carried by A delta and C fiber. A delta and C fibers they will terminate at DRG. From there, first order neuron will arise. This first order neuron will go into a special area of spinal cord known as substantia gelatinosa. From there, second order neuron will arise. They will decussate and decussate and go on lateral side. They are going to thalamus. That's why they are known as spinothalamic tract. And they are in lateral part. That's why known as lateral spinothalamic tract. They will go above and at the level of upper medulla, they will join with anterior spinothalamic tract and tectospinal tract. When they join with all this tract, the special group is known as spinal lemniscus. So we'll move further. Now suppose this is upper part of medulla. Where these fibers are joined by other fibers and they are known as spinal lemniscus. Okay. Now, Now, there is a special area. This is thalamus. And there's special nucleus in thalamus where they terminate, which is VPL, which is ventro posterior lateral nucleus of thalamus. Now, this tract will go in VPL nucleus of thalamus. Okay. From there, now we all know that thalamus is a relay center of sensory information. Now, this information will project in sensory cortex. Okay. Now, through this, our body will get to know that there is something pain stimulus is there. Now, there is one more interesting thing what is happening right now. I've told you previously that there are two kinds of fiber, A delta and C. Now, A delta is a myelinated. That's why it carry positive. And C fiber is unmyelinated. It carry slow pain. Now, suppose there is this slow fiber. Now, what this slow fiber will do, there is a long reticular system. This slow fiber will give its information to this reticular system also. Now, we all know the reticular system is a center for awakening us. So, while going upward, this slow fiber gave it some collateral to reticular system. That's why when we are having chronic kind of pain, a slow pain, we can't see. This is because of this. Now, this slow fiber will also give some fibers here to this region. Now, what is this? This is cingulate gyrus. Cingulate gyrus. And it is in limbic system. So when slow fiber gives some of fiber to cingulate gyrus in limbic system, that's why there is some emotional component is in pain. That someone will cry, someone will be cry more. Sometimes a normal slap will made us to cry more. So this emotional component comes through this cingulate gyrus. So slow fiber while going upward gives some fiber to reticular system. They also give some fiber to cingulate gyrus. That's why we have emotional component. And also there is, this area in brain. This is insula. Some fibers go there also. Now, what this fiber will do here? Now, these fibers will lead to an autonomic response in pain. So, it will lead to nausea, vomiting, plus increase in heart rate. So, all these will lead to our ascending nervous system. So, we will start from again. How ascending pain fibers go. A delta C fiber, they'll terminate in DRG. From DRG, first order neuron will rise. First order neuron will go into substantia gelatinosa. From there, second order neuron will rise. They will decussate and lead to formation of lateral spinothalamic tract. The lateral spinothalamic tract will go to thalamus. In thalamus, it will give it information in BPL nucleus of thalamus. Thalamus will separate this information in sensory cortex. Going upwards, slow fiber have some collaterals with reticular system. That's why we are always awakened while there is sleep. And they have also some fibers to cingulate gyrus, which is a part of a limbic system. That's why we are having some emotional component. And they give some fibers to insular region. That's why we are also having nausea, vomiting, and increase in heart rate also. Now, this is a substantial gelatinous area, what I've told you previously. Now, this is a diagram, same diagram which I have explained earlier. There is some afferent fiber for temperature and pain. They will go and terminate in DRG, that is spinal ganglion. From spinal ganglion, first order neuron will arise. They will terminate in a special spinal cord that is known as substantia gelatinosa. From there, they will move forward and they will go to ventral posterior nuclei of thalamus. And from thalamus, this information will read you to sensory cortex. And there's one more important thing that I will tell you. You can see that this these are two fibers of the spinal human tract, and the upper fiber is medial to below fiber. You see now this fiber, there are two fibers, and upper fibers are medial. So what this means that while we are going upwards, the fibers which are from upper spinal cord section, they are added medial, not lateral. Okay. Now distinguish between what is fast pain and slow pain. Now, I've already told you that A delta fibers are myelinated fiber. They are thin, but they are myelinated. That's why they carry fast pain. And fast pain is near about 0.1 second. Like suppose there's a prick in my finger. This is fast pain. It has short latency and it is well localized. Slow pain is like there is a pain, but you feel like you will feel this about 20-30 minutes later. This is carried by C fiber, which is very slower in onset and kind of diffuse. Means you can't localize. Suppose abdominal pain, you can't localize it where is abdominal pain. But if someone has cutted your finger, you can localize. This, this is the point, doctor. There's my finger is cut. But you can't localize abdominal pain. You will say, yes, sir, in this area there is pain, but you can't say that this or that. That is slow pain. It is of longer duration. Fast pain is less emotional, and slow pain is more emotional and more autonomic response. So that's why I say, suppose you are having headache, you can't sleep, you will have some emotional component. You're having abdominal pain, you will cry with that pain. That's what I've told because slow pain fibers give there some collaterals to cingulate gyrus as well as to reticular system. That's why it is having some emotional autonomic response. And autonomic response is in form of nausea, vomiting, increase in headache. That's why you will find some patient, they are having headache, then they will get into vomiting and something like nausea. So you will get to know the reason. Because these fibers give some fibers to insula area, which is responsible for that autonomic response. Fast pain is mostly from superficial structure. It is carried by spinothalamic lamina 1 and 5 and slow pain is by superficial deep structure, spinal reticular lamina 1 and 2. And both can see that both are by VPN nucleus. But slow pain is by VPN intraluminal nucleus. Now, I will tell you what is this intraluminal nucleus. I mean, now, this is thalamus. We don't know. In center of thalamus, there is white matter. And in this white matter, there are some cell bodies of gray matter. These are known as interlaminar nuclei of thalamus. Okay. Now, this slow pin fiber, when ascending upwards, it gives some fibers to VPL nucleus. Or we all know that all fast pin slow pin give their fibers to VPL nucleus. But the slow pin will give it some fibers to interlaminar nucleus of thalamus. Now, what is interlaminar nucleus of thalamus? Now, I have told you that there is some reticular system there. Okay, this is a reticular system. It extends on full brain stem. There is midbrain. This is pons, and there is a medulla. This reticular system is in midbrain, pons, and medulla. Now, this reticular system has also some connections with interlaminar nucleus of thalamus. So that's how it amplifies the awakening because slow pain fiber is also having connection with reticular system. It is also having connection with interlaminar nucleus thalamus, and reticular system is also having connection with interlaminar nucleus thalamus. That's how pain get amplified. can't even see it because there are having two connections. One is with retro system and other is with interlaminar nucleus thalamus. And interlaminar nucleus thalamus is also having connection with reticular system. Now, now other topic is pain modulation. Now we will see what is pain modulation. Now, what concept is pain modulation? It is like that something which is happening in our body by itself to reduce the pain because our body is smart. It doesn't want that we should cry in pain. So it will do some kind of activity that our pain should subside. So we will now suppose this is my spinal cord. Okay, the center of canal. This is DRG, dorsal root of ganglion. Okay. Now we all know A delta and C fibers carry pain sensation. They will terminate here. From here, first order neuron will arise. Let me go with another time. Good evening, Namrat Chauhan. From the sir, you take classes only on YouTube. Yes, right now we are taking classes only on YouTube. Huh. From A delta and C fiber, first order neuron will arise and they will go in this area, substantia gelatinous. From here, second order neuron will arise. Now, see, I will tell you one more. The first order neuron and second order neuron meet in the area of substantia gelatinous. And this synapse between first order neuron and second order neuron is known as gate. Now you will ask me what is gate. So I will tell you in my further section what is gate. Right now you just remember that synapse between first order neuron and second order neuron is known as gate. Now what will happen? Suppose there is what scientists have seen that we all know that there is also because this is a nerve fiber. It contains all kinds of fiber: A delta fiber, C fiber, A alpha, and A beta. And A beta fiber carry touch. Okay. Now suppose this is a A beta fiber coming. Okay. Now it will go and go. Now this A beta fiber has some small intraneuron on this synapse. See, this A beta fiber, it will go further, but it has one interneuron connection with this synapse of first order and second order neuron. Now, what this interneuron will do? It will inhibit this synapse. So, what I mean, I have, I have told you that synapse between first order and second order is known as gate, and there's a beta fiber which is going and it is having some interneuron connection with this synapse, and it always try to inhibit this synapse. Okay, and A beta fiber, when it will be stimulated, it will be stimulated with touch, with any kind of massage. So when A beta fiber will stimulate and it will inhibit this gate. So if we are inhibiting any kind of gate, what we call? We will call this we are controlling something. If we are inhibiting something, we are controlling something. And if we are controlling, we will call it a gate control theory. So this is how you get a name of gate control theory. And we all know that whenever there is a pain and we massage that area, pain will subside. This is the reason. Because that A beta fiber has some interneuron connection which inhibit that synapse. And we are inhibiting something, it means we are controlling that. And we are controlling that thing. So we have what we call it as gate control theory. Because at the time of research, what scientists found is that this is a gate between first order and second order neuron. And some interneuron is stopping it. That's why we call it as a gate control theory. Now, I will again draw a diagram of spine. And this is central canal. Okay. Now, when we go above, we know that there is one thing known as third ventricle. And we- on side of third ventricle is our favorite section, that is thalamus. Okay. Now, you all know that third ventricle is connected with cerebral aqueduct. Okay. Now, area near this, the third ventricle, is known as periventricular gray matter. And a gray cell bodies near cerebral aqueduct. Now, what are cell bodies? You know na, that cell bodies are gray matter in CNS system. These are known as PAG, that is periaqueductal gray matter. So, cell bodies near third ventricle are known as periventricular gray matter. Cell bodies near cerebral aqueduct is known as periaqueductal gray matter. Now, now this A delta and C fibers are carrying pain. This is first order neuron. Then there are again synapses. From here, second order neuron will arise. Okay. Now, from periventricular gray matter and periaqueductal gray matter, some descending tracts come down. And what this descending tract will do? They also have some interneuron connections with this gate. And what is gate? Gate is the synapse between first order neuron and second order neuron. They also inhibit this synapse through this interneuron. And what scientists have noticed that when they inhibit, so they release some chemicals. And what are the chemicals they descending tract release? It release endorphins and enkephalins. And this endorphin and caffeine, they all have structure like opioids. So descending tracts coming from periaqueductal gray matter and periventricular gray matter have some interneuron connection with that synapse of first order neuron, second order neuron. And through that interneuron, it inhibits this. And what chemical through that inhibit that are known as endorphin and caffeine. And they are just opioids like structure. So in our body itself, there is a mechanism of releasing opioids. That is mechanism given by to us by God, that through central mechanism, through pH in PVG, we are getting release of some chemicals which inhibits this synapse. So that's why there is decrease of pain. So that's why when we say, no, that's meeting to some good one will, will reduce my pain. That's how this happens. This central mechanism will come to play and opioids will release through our endogenous system and pain will be subside. Now you can see in this diagram, periaqueductal gray matter is there. So the designing texts are coming. There's another thing is rostral ventral medulla. All these they are inhibiting through interneuron. Okay. Now this is known as pain modulation pathway. Now descending pathway comes from neurons from PAG, travels down to synapse of the posterior spinal cord that we have studied. And they have inhibitory effect on synapse we have studied. And this inhibition perception of pain is there. Now, there are some also other areas are also there except PAG and parietal grammatar. These areas are known as rostral ventromedial medulla, and other is known as anterior cingulate cortex. So you should remember this other area also because these are MCQ questions. Now, I will tell you one thing. Now, suppose in Harrison, this example is mentioned that a soldier who is fighting at the borders will not receive that much pain of any cut and bruise that a common civilian will face. Because in soldier, their pain modulation pathways is so much adjusted and give them so much placebo effect that they will not feel that much pain. And every individual, this pain modulation pathway will vary. So if there is a cut, soldier will not feel pain because their pain modulation pathway works at very efficient manner and very good placebo effect is there. But a common civilian will get pain because their pain modulation pathway is not that much, you can say, good or net or not that much good that it can inhibit pain. So this pain modulation pathway also vary from individual to individual, and that's why some people will receive different kinds of pain depending on their situation. So in Harrison, this figure is given, and what they are trying to show that patterns of brain activity during placebo analgesia. So they have collected a RCT trial was there, and they've collected a patient around, suppose they are collected around 200,000 patients. And what they have found when they have done MRI of this patient, they found that some areas of brain, their activity was increased when there was placebo effect of analgesia. And what was this area? First was dorsal lateral prefrontal cortex. This is DLPS. Dorsal lateral prefrontal cortex. Other area was rostral anterior cingulate cortex. Other was rostral ventral medulla, and other was pericortical gray area. So they found these four areas. So these four areas behave like a pain modulation path. So okay, you should remember this area because there are potential MCQs for future. Now we'll come to neuropathic pain. Now what is neuropathic pain? It is any burning, shooting kind of pain and electrical pain will be itching and throbbing kind of pain. And there will be dysesthesia and paresthesia. Now, this dysesthesia and paresthesia are classical for any neuropathic type of pain. There is also other type of pain known as sympathetically maintained pain. Now, what does this mean? Any patient which is having any peripheral nerve injury occasionally develops a spontaneous pain in or beyond the region, which is innervated by that nerve. And this pain often has a burning quality. And this pain can be relieved by any local anesthetic block. Okay. And they have given this pain a name of a complex, but this sympathetic dysfunction happened after the injury. So what they're trying to say that whenever any individual get an injury, after injury, few days back, they have seen that there is edema, swelling, and some inflammation kind of thing is there. And pain happens after 2 or 3 weeks. Okay. And there's some sympathetic activity also there. They have mentioned this as a complex regional pain syndrome. So whenever you are practicing in OPD in Euro OPD, you will see this kind of patient. They will come you with that. They will say that there is some kind of pain is there, and you will find that their hand is little bit swelling is there, some redness is there that defines inflammation. And if you take history properly, you will find that there is something injury in which is preceding 1 week back or 2 week back. So injury and after injury, pain is happening after 2 or 3 weeks, which is having inflammation and swelling. It is known as complex regional pain syndrome. Now we will come to classification of pain. Now pain is classified on in acute and chronic basis. Now there is so much guidance that it is acute or chronic, but generally, what in our current practice we say that acute pain is less than 3 months and chronic pain is greater than 3 months. Treatment of acute pain. Now, for acute pain, drug of choice is always NSAIDs, and second line option are opioids. Now, when we are prescribing NSAIDs to anyone, you should remember that one common formula that there are two types of NSAID. One is non-selective that inhibits both COX-1 and COX-2. Another is selective that inhibits only COX-2. Now, generally, what we say that NSAID can lead to peptic ulcer disease. Okay, and this is one of the most common causative agents for peptic ulcer disease. But non-selective leads to peptic ulcer disease. Selective decrease the chance of peptic ulcer disease, but they increase the chance of MI and stroke. So whenever you're prescribing NSAIDs, if this patient is having any history of CAD, MI, don't prescribe because selective COX inhibitor increase the risk for MI and stroke. And what are selective inhibitor? They are sulfoxyglide. So we generally use them in arthritis. Now you can see that there is a one NSAID that is naproxen, which is given around 200 to 500 mg per whole OD, and generally it is like a BD dosing to allow it. And naproxen is the NSAID that has least cardiovascular risk, that has least cardiovascular risk. This is also NSAID, but it has somewhat high. So any NSAID decrease the chance of MI and so and vice versa. Okay, that was common formula that you should already. Now coming to opioids. Now most common drug used in management of pain, most I can say the drug which is most abused is also opioids. Okay. Now what kind of drugs are in opioids? They are morphine, heroin, codeine, methadone, fentanyl, tramadol. Generally, we prescribe tramadol and all these things. So, whenever we are prescribing opioids or we are dealing with any patient who's taking opioid, we should remember SAC wrong. Okay, opioids work with the help of their receptor mu, kappa, and delta. Okay, now what I've said to you, that always when you are prescribing opioid, remember this Nociception. What does S mean? S stands for sedation. S stands for sedation. So what will opioid will do? It will do sedation. If large dose of opioid is given, it will result in coma. Okay. A. What A stands for? A stands for analgesia effect. They are having. That's why they are using pain. C, which is most important, is constipation. Okay. So how can we use that? Any patient who is having diarrhea, we can prescribe opioids. You all know a common opioid which we usually prescribe to any patient having diarrhea, that is loperamide. This is opioid. R. R stands for respiratory depression. Why have put on 3 star? Before prescribing any opioids to any patient, check that patient is having any respiratory illness or not. If he is having any acute asthma, any COPD, any kind of thing, don't prescribe it because opioids carry a major risk with opioid is respiratory depression. U U stands for euphoria. M M stands for narcissism. Okay. Now, what are there are two most important contraindications you should always remember with opioid. One is head injury. You should never prescribe opioid to an injury of head injury. Why? Because what opioid do, opioids will lead to increase in ICT. That's why we should not prescribe them in head injury. And other thing, what they will do, no, you will know that in opioid there is meiosis, and in increased ICT also there is meiosis. So if we want to check if our patient is progressing or not, how will we check? Because opioid themselves will do meiosis. So it will hamper or interfere with the program to be of cautious when you're prescribing opioid. What is the antidote of opioid? That is naloxone. And for maintenance in opioid poisoning, we use naltrexone. Okay. And remember one more thing that is special about naloxone. Naloxone effect comes in around 1 or 2 minutes. And naloxone is a kind of drug that can be given by endotracheal route. So, okay, this is the most important thing about naloxone. Now, coming to opioids, the most important thing which you have to see in this table of medicine that is methadone. Dose is around 5 to 10 mg, can be given as PDS or QID. Now, methadone has a long half-life. Okay, that's why respite, depression, and sedation may persist after analgesic effects. So this is the most important thing you have to taking from methadone because it has a long half-life. Other is that there is fentanyl, which has 72-hour transdermal patches. They kind of opioid. Okay, and there is one thing which comes in market that is oxycodone. It has an oral extended release tablet which has a high potential for misuse. Now, there's another thing that is used for this kind of patient is PCA, patient control analgesia. Now, what this will do, it has a microprocessor and a control infusion devices there, which delivers a continuous dose of an opioid drug, as well as a pre-programmed additional doses. Whenever the patient pushes a button, drug will be there. So it's kind of an optimal level. So here, opioid toxicity condition can be avoided by prescribing patient with PCA. Now comes to treatment for chronic pain. In chronic pain, PC are the most effective drugs, but that are tricyclic antidepressant. They are the most effective drugs that can be used. But problem with PC is that we can't increase their dose too much because they carry too much side effects. Okay, and most commonly used PCR, nortriptyline, and desipramine. Other are SSRI. Now, SSRI are alternative to PCA, but problem with SSRI is that they have very poor analgesic effect. So that's why they are not preferred that way. Other are serotonin, norepinephrine reuptake inhibitor. They are better alternative to SSRI, but compared to TCS, they are lower. Contain pregabalin, phenytoin, carbamazepine, and in last, the most important drug which we can prescribe in any kind of pain that is acute or chronic, that is our opioids. Now, this is a important table which is given in Harris study that tells about painful condition that responds to TCA antidepressants. They are post-therapeutic neuralgia, diabetic neuropathy, fibromyalgia, tension headache, migraine headache, rheumatoid arthritis, chronic low back pain, cancer, and central post-stroke pain. Now, when you will see chronic low back pain, they have mentioned something about chronic low back pain is B. And when you come to B, you found that in B, they have mentioned control studies indicate benefit, but not analgesia. So, what they found when they used EC in a chronic low back patient, they found that there is some kind of benefit, but that is not benefit of analgesia. So TC is benefiting in chronic low back pain, but why we are using this? We are using for analgesia effect, but there is no analgesia effect in chronic low back pain. But there is some kind of benefit is there. So this is one of the most important MCQ point you should remember. Now we'll come to table. Here we can see that pregabalin and gabapentin is there. Dose is generally around 150 mg to 600 mg BID. You must remember that one of the most important side effects that we generally miss in our OPD when we are prescribing pregabalin and gabapentin is that dry mouth and edema. Okay, these are TC antidepressants are there, all have a side effect of orthostatic hypotension, and they also increase the risk of cardiac arrhythmia. Okay, in this there is which you should which is most important, which you should always remember is that is this amitriptyline. It has cardiac arrhythmia potential. Dose is 150. Okay, and other question generally asked on this vanilla fat. It it doesn't have any effect on cardiac arrhythmia and doesn't have any effect on orthostatic hypotension. And dose is around 150 mg per day. That is average. So now, now I tell you that any kind of pain is there. When it is acute or chronic, we prescribe a drug that is opioids. And opioids is the most misused drug in treatment of pain. So CDC, that is Center for Disease Control and Prevention, has come with some guidelines in 2016 for every practitioner. Is that you should know when to initiate or continue opioids for chronic pain. Most thing. Second, opioid selection, their dosage and their duration, their follow-up and discontinuation is important. And third, when we are prescribing opioids to any patient, we should know what are the risks and harms of this drug can have in future. So by considering all these factors, we should try to optimize our drug and then we prescribe it to our patient. Okay. Now we will see some previous year questions which are asked in NEET as 2023 related to pain. Now, first question is that which of the following is the central area of sensitization of pain perception? So, I have told you previously that they are what sensitization I have told you, and there are two areas. Peripheral sensitization is there, and there is central sensitization. In peripheral sensitization, you are receiving pain with a low threshold. Earlier, you were receiving pain with 2 ml of acid. Now, you are receiving patient pain with 1 ml of acid. In central sensitization, what is happening? There are some neuroplastic changes that are there. So, you are getting pain on touch also. Earlier, touch is a touch is a non-stimuli. Generally, you can't receive pain on touch. But now you are receiving pain on touch also. That is allodynia. That is central sensitization. Peripheral sensitization happens at the level of peripheral nerve. Central sensitization happens at the level of dorsal root of or dorsal horn of spinal cord. So answer will be D. We are going above. Here, it is clearly mentioned in Harrison that at the level of dorsal horn of spinal cord, there is central sensitization. Now, these all are MCQs questions. Peripheral sensitization is at the level of peripheral. Okay. Other question. The placebo effect of pain perception is mediated at which level? Options are spinothalamic tract, rostral medial medulla. Third is peripheral nociceptor, and last is dorsal root of ganglia. Now, we all know the placebo effect on pain modulation. There's a descending pathway, and there's also a touch pathway, A beta fiber. And there are four areas mentioned in Harrison that they have seen on MRI. First, we will see what Harrison has mentioned that have been told previously. They have mentioned four areas. One is dorsal lateral prefrontal cortex. Second is rostral anterior cingulate cortex. Third is rostral ventral medulla. And fourth is pericaudal gray matter and periventral gray matter. So, by coming to options, spinal tech, no. Peripheral nociceptors, no. Dorsal root ganglia, it is for central sensitization. So, what option is there? Rostral ventromedial medulla. Okay. Just before closing the session, the most important crux point I have tell you, and that is of ascending pain pathway. Okay, ascending, that is first order neuron, that is DRG. Then comes second order at the level of substantia gelatinosa. Then they decassate. Okay, it will move upwards. They terminate in VPL of LMS. Then slow fibers. Sorry, slow pain fibers. They have some connections with reticular system, with insula, with cingulate gyrus. It is responsible for awakening. This is responsible for pain and emotional component. This is responsible for autonomic response. Okay, so this is our ascending pathway. And last is what our pain modulation pathway. It is at two levels. First, at the level of touch through A beta fibers, also known as gate control theory. Okay. Second, through central mechanisms, that is through PAG, through rostral ventriculomedulla part, DPFLSC. Okay. So this much you have to study in pain, and I guess these is more than enough to answer any MCQ related to pain that will ask in any competitive exam or writing any kind of question. Okay. Thank you.